My name is Chris Röcken. I'm a surgical pathologist from Kiel, North Germany, and I'm doing business with amyloid for 32 years. And when I started amyloid research, everybody said, so what? And now we say, we have treatment. And that has totally changed. 32 years ago, we didn't have any treatment. Now we have medicine, and this is a huge advancement. So I'm really happy to be here and witnessing the advancements we have made over the last 32 years. So what am I doing? I'm diagnosing amyloid, and how does it look like when I see it? It's in, you see on the left tissue biopsy samples. Upper left, this is a heart biopsy. Upper right is a kidney biopsy. I have a point, I see. Yes. So this is a kidney biopsy, this is a gastric biopsy, and this is a liver biopsy. And on an H&E staining, it's a routine staining we do with every specimen we have, and it shows a homogeneous eosinophilic mass, which is replacing cells and tissue, and thereby leads to organ dysfunction. However, if I see that, I have a suspicion, but that doesn't mean it's amyloid, because a couple of changes in tissue which can mimic amyloid. So I do congruent staining. It's an ancient staining, more than 100 years old, but still working. And it's the gold standard to diagnose amyloid. And if I use then a polarizing microscope, that turns the light into darkness, but amyloid into green birefringence. If I see that, I make the diagnosis amyloid. Full stop. You can do on top electron microscopy. Only very few departments of pathology do electron microscopy, usually only nephropathologists. No other pathologist applies electron microscopy. But when you do it, you can see these rigid fibrils, which are the aggregates of proteins present in the tissue and causing organ dysfunction. It's not one disease. It's a group of diseases. We now know more than 42 different types of proteins which can form amyloid. And the spectrum, as already mentioned by the preceding talk, it's a very complex clinical presentation. And that makes it difficult. Some of these are unimportant. They will not kill a patient at all. But some of them may be killers. So that's the issue, differentiating what is important from what is unimportant. And even 150 years after Rudolf Virchow termed the name amyloid and described it, it's still the pathologist being involved in diagnostics and playing an important role for every patient, usually. And once we have made the diagnosis, once we have recognized the amyloid in the tissue sample, we need to classify it. We need to know which of these types is present. Because we have different types of amyloid, it's a very heterogeneous group of diseases. Sometimes I get calls from patients that are very excited with amyloid. They look into the internet and think, horrible, am I dead in a month's time? Say, no, that amyloid type is unimportant. You can live it for a long time. It will not affect you at all. But some are very dangerous. They can be life-threatening, particularly AL amyloidosis. Not every type of AL amyloidosis. We need to differentiate between a systemic form, where you find the amyloid deposits in various types of organs and tissues, including heart, including kidney, including GI tract, and sometimes maybe only locally, mass forming, where you have a much better prognosis. And that's really important to differentiate that. We have treatable diseases, such as AL amyloidosis, but we have also untreatable forms of amyloidosis, but this is not the topic of this conference today. But there are some forms of amyloid for which we do not have currently any treatment. That just needs to be mentioned. So it matters not only to diagnose amyloid, but also to classify it. It's a sine qua non now in 2024. So what are the clinical situations which I'm facing? One has already been presented. There has a clinical suspicion, such as monoclonal gammopathy of unknown significance that has been nicely presented, or underlying other clinical symptom, which is a red flag, such as carpal tunnel syndrome, or polyneuropathy, a peripheral symptom. But there may obviously no clinical suspicion, which in my expertise is far more common. That is a finding by the pathologist. The clinician hasn't thought about it. Was completely surprised by the diagnosis. And then there's a situation which I'm in, that I'm a tertiary referral center. I'm a specialist on amyloid diagnostics, and I receive on average more than 1,000 samples a year where amyloid has been confirmed, and I do the classification. So I see many patients every day, but that's very unique. And it's not the reality for the average surgical pathologist who sees amyloid once or twice a year. So now, where are they, the amyloid deposits? When I'm a clinician, I'm raised suspicion, where should I look for? Everything starts with a decent microscope, and what you really need is a polarization microscope, because this is a special microscope, and I get a lot of cases referred, query amyloid, and I say, no, there's no amyloid in it. Or yes, there is amyloid in it, where they had no idea. So that really starts with a microscope, which is a special microscope with tension-free optics and need very dark field to see that the light is blacked out and then amyloid shows up. So I can say this is very important. After 32 years of doing diagnostics, I realize many cases are overlooked or interpreted wrongly as amyloid, where there is no amyloid because they didn't use the polarization microscope. So let's go through some organs. Upper and lower GI endoscopy is something many patients undergo. Sometimes because they have some stomach ache, or they look for a prevention of cancer, colon cancer, polyps. So upper and lower GI endoscopy is very frequent, and commonly biopsies are taken for query gastritis, query colitis, etc. You may detect amyloid in these, and AL is frequently deposited also in GI. So among all the different types of amyloid we can find in biopsies of the lower and upper gastrointestinal tract, AL amyloidosis is among the most common we find. So yes, if there's any suspicion of AL amyloidosis, and there has been recently a biopsy taken from the upper lower GI, look for amyloid. You do not need to do re-biopsy, just ask the pathologist, look at the biopsy sample which has been taken a few weeks ago. Can you find amyloid? It may have been very tiny and not recognized by H&E staining. So AL is in the upper and lower GI tract among the most common types of amyloid we find. Cardiac biopsies. There has been a move recently. We did a study almost 14 years ago, and at that time, AL and ATTR, another very common type of amyloid in the elderly population, had equal percentages. That has changed recently. More and more cardiologists perform cardiac biopsy, and this assessment was done very recently. We reviewed our cases. We have more than 12,000 cases of amyloid in our registry, and 1,300 heart biopsies, and TTR amyloid turns out to be one of the most prevalent types in cardiac biopsy. So there has been a shift, but still AL amyloidosis is the second most common. So not every cardiac biopsy is AL amyloid. This is the message. And it's very important to differentiate a cardiac biopsy, whether it is AL or ATTR. And very, very occasionally we see both types in a cardiac biopsy, AL and ATTR amyloid. Kidney biopsy. Many patients show up with proteinuria and renal failure, and therefore a kidney biopsy is taken. Query what is the cause of loss of proteins in the urine. And then this nepropathologist is one of those pathologists who is the first to detect amyloid. And the spectrum of the differential diagnosis, or the types of amyloid which can affect the kidney, is the broadest there. You can have AL, but you can also have hereditary types of amyloid. So you need to classify, but AL amyloidosis is about half of all cases at minimum, which affects the kidney. There's an increasing awareness among orthopedics, hand surgeons, neurosurgeons, that amyloid also occurs in the specimens they resect, such as carpal tunnel syndrome, spinal canal stenosis, and so forth. Most of those cases are ATTR. AL very, very rarely presents at these sites. However, carpal tunnel syndrome is a reflex syndrome, symptom, But among the large number of patients with carpal tunnel syndrome, ATTR is the dominant type of amyloid. AL is rare among all cases with carpal tunnel syndrome. If you look from the side of a patient with AL amyloidosis, then carpal tunnel syndrome may be more prevalent. But looking from the side of as hand surgeon or the patient with carpal tunnel syndrome, the majority has ATTR amyloid. And that's what's shown here. In our registry, more than 95% with carpal tunnel syndrome are ATTR now. That has changed the awareness. Formerly, when we presented the data the first time, all said, no, it must be AL. No, I said it's ATTR, in fact. Some patients with AL amyloidosis present with polyneuropathy, and occasionally the neurologist may consider taking a neuronerve biopsy. And yes, some patients with AL amyloidosis indeed have deposits in the peripheral nerves, and you see here about very few, we have very few cases. That's because neuronerve biopsy is not the main site neurologists like to take biopsies, because patients sometimes have this as T-shirts, say, well, if there's another way to make a diagnosis, we try not to take a neuronerve biopsy. A fat PET biopsy is a more and more commonly used technique to diagnose amyloid. So if there's suspicion of AL amyloidosis, I recommend, if there has not been a biopsy of the upper and lower gastrointestinal tract, or there has not been a cardiac biopsy, then fat PET biopsy is really the best way to screen for AL amyloid. ATTR amyloid very rarely presents in fat PET biopsy, so I show here an example, but really this is a rarity. There are different ways how to take a fat PET biopsy. You can take a syringe or you can do a surgical procedure. I recommend surgical procedure because there is a risk of sampling error. Sometimes amyloid deposits can be very sparse in the fat PET biopsy. So if there is a chance, take a surgical resection specimen to get enough material for recognizing amyloid. And if it's negative, it does not exclude AL amyloidosis. That must be clear. You always have the risk of a sampling error. When it comes to early recognition, my recommendation is go for it, go for the organ which is symptomatic, if fat PET biopsy is negative. So if the kidney is showing up, take a kidney biopsy. If it's heart showing up clinically, then take a heart biopsy when the fat PET biopsy is negative. However, the number of cases where we diagnose AL amyloidosis in fat PET biopsy is consistently increasing because the procedures are becoming more and more used. The knowledge is increasing with those who take the biopsies, and we have an increasing number of patients with AL amyloid and fat PET biopsies. So beyond histology and classification, what can we do else? We do on cardiac biopsies quantification of amyloid load. We quantify the amyloid load, and we believe it's clinically important. This is the distribution of amyloid load. So if you hear it's about 19% amyloid load in the heart, sounds not very much. Indeed, it is a lot. And we do not find amyloid load beyond 70%. That means patients who have more than 70% amyloid load in the heart will not live anymore, or not very long. So the median means 50% of the patients we see are clinically symptomatic and have amyloid in the heart. And a couple of years ago, we related the amyloid load with outcome and therapeutic response, and we recognized patients with less than 20% amyloid load in the heart benefit from therapy. If they have more than 20%, unfortunately, there's no big therapeutic response. So there seems to be a certain amount, there seems to be a level of amyloid load in the heart where treatment fails in the end. So the earlier we find the patient, the greater are the chances that you are successful in treatment. So, underscoring your talk, actually. So there has been a recommendation recently from a couple of very famous clinicians about histological type in patients, which I refer to. And this is just cardiac biopsy. I skipped those slides because I have short in time. And they also propose proteomics to classify amyloid. Yes, you can use proteomics. I personally don't think it's a gold standard. It's more like a silver standard. And why proteomics? You can find rare types with proteomics, that's true. Unknown types. But the amyloid protein is not only the fiber protein. We reviewed all the literature on proteomics on amyloid, so deciphering all the proteins present in an amyloid deposit, and it's in a gemisch, it's a mixture of proteins, and you need to be aware of that. That it sometimes may be very tricky, even proteomics, to classify amyloid. So summing up my talk, how do we improve accurate diagnosis in 2024? First of all, my statement is you need a decent microscopic equipment. If you don't have it, you don't find the amyloid deposits or you misclassify it. I think it's a sine qua non. You need a surgical pathologist who has a special interest, who is trained. It's not only proteomics, for instance, or just immunohistochemistry. You need to know the diseases. And most of the diagnosis I make is I look at the case, I look at the specimen, and I could say without any type, and this is AL amyloidosis, or this is another type of amyloid. So it needs expertise, really, and I have 32 years of expertise. So typing is more than a technique, it's also knowing the deposition patterns and the disease. We use laboratory lab tests for immunohistochemistries, and proteomics is not a gold standard, it's a silver standard. There are different techniques, and which finally lead to proper classification of the amyloid deposits. So that's the end of my talk. Thank you very much for listening.